Welcome back everyone, my name is Craig Harrison. In this presentation we will be discussing the complications associated with diabetes and the treatment options available. Firstly though, let's revisit the differences between type 1 and type 2 diabetes. For type 1 diabetes, the onset of symptoms is sudden and corresponds to the near complete destruction of beta cells and the loss of insulin production. Whereas the pathogenesis of type 2 diabetes is much more gradual and can often remain undiagnosed for many years. Type 1 diabetes generally develops in childhood, while type 2 diabetes occurs later in life. Furthermore, type 1 diabetics present with normal or reduced body mass, whereas type 2 diabetics are often overweight or obese. Some common features of type 1 diabetes are ketoacidosis and the presence of autoantibodies. However, both of these are rare or completely absent in patients with type 2 diabetes. Endogenous insulin is low or absent in type 1 diabetics, but can actually be normal, low or high in type 2 diabetics, and this is dependent on the stage of the disease. And finally, there is a greater genetic component to type 2 diabetes, and it is by far the most prevalent form of the condition. The lack of insulin, or a lack of insulin activity, creates a profoundly catabolic state, which causes numerous acute effects throughout the body. These include excessive thirst, which is called polydipsia, excessive hunger, which is called polyphagia, lethargy, and stupor, which is basically a severe lack of energy. In addition, systemic weight loss due to increased breakdown of fat and muscle to provide alternate forms of energy is commonly observed in type 1 diabetics. Another common symptom associated with the lack of insulin is Kussmaul breathing, which is a much deeper and more laboured type of breathing. This is triggered by the process of ketoacidosis. When fats, rather than carbohydrates, are broken down, they release ketones that accumulate and raise blood acidity. By hyperventilating, the lungs can expel more acidic CO2 than normal and thereby partially offset acidosis. High levels of blood sugar resulting from diabetes can also affect your ability to see by causing the lens inside the eye to swell, which can result in temporary blurring of vision. The GI tract can also be strongly affected in diabetes, with both hyper and hypoglycemia inducing nausea and vomiting. Finally, polyuria is a condition where the body urinates more than usual and passes excessive or abnormally large amounts of urine whenever urination occurs. This is caused by polydipsia, but is also due to excess glucose in the blood. This is because not all of the sugar can be reabsorbed, and some of this excess glucose from the blood ends up in the urine, where it draws more water. All of these acute complications can affect diabetics on a day-to-day basis if their insulin levels are not maintained as required. However, there are also many chronic complications associated with diabetes. Indeed, prolonged hypoglycemia can lead to the damage of many organs, including eyes, kidneys, nerves, heart, and blood vessels. These complications are routinely separated into microvascular and macrovascular complications. Macrovascular complications include cerebrovascular disease within the brain, coronary artery disease within the heart, and peripheral vascular disease in the extremities, which can result in ulceration, gangrene, and amputation. Unfortunately, as a result, 4,400 diabetes-related amputations are performed in Australia every year, which equates to roughly 12 amputations a day. Microvascular complications include eye disease, such as retinopathy, cataracts and glaucoma, nephropathy in the kidneys, and neuropathy in the nerves. In the microvascular complications of diabetes, hypoglycemia damages blood vessels and can lead to the process called atherosclerosis, which is the clogging of arteries. The resultant decrease in blood flow can cause heart attacks, strokes in the brain, as well as pain and decreased healing in the extremities. The association between diabetes and cardiovascular disease are profound. People with diabetes are 2 to 4 times more likely to have heart disease or stroke, and 2 out of every 3 people with diabetes die from these cardiovascular diseases. The microvascular complications of diabetes are somewhat different to the macrovascular complications in that they are characterized by vasoconstriction, increased capillary permeability, proliferation of the extracellular matrix, and capillary occlusion. All these aspects can be seen in this image of retinopathy, where we can see hemorrhage or increased permeability, abnormal blood vessel growth, aneurysm associated with capillary occlusion, and fibrous tissue caused by increased extracellular matrix deposition. Retinopathy is the leading cause of blindness in diabetes, and it affects 80% of individuals who have had diabetes for greater than 20 years. In the kidney, high glucose in the filtrate causes increased urine excretion and renin secretion, which together lead to vasoconstriction of renal arterioles and infarction, that is, an obstruction of the blood supply to the surrounding tissue. Over time, this lack of blood supply causes glomeruli to die. Diabetic nephropathy is the most common cause of chronic kidney failure and end-stage kidney disease, and is the leading cause of premature death in diabetic patients aged between 50 and 70 years. The microvascular complications of diabetes can also contribute to neuropathy or damaged nerves, as shown in this image. High glucose levels can also damage nerve fibres directly, and depending on the affected nerves, symptoms can range from pain and numbness in the extremities to problems with the digestive system, urinary tract, blood vessels, and the heart itself. Now, good control of blood glucose levels has been shown to decrease the risk of all complications associated with diabetes. Other factors which can help are the normal recommendations of eating better, getting active, losing weight, managing blood pressure and cholesterol, and quitting the smokes. So what treatment options are available for type 1 diabetics? Looking back in history, diabetes was first described in ancient Egypt around 3500 BC, and back then it was 100% fatal. And up until 1922, the only treatment option available was a starvation diet, which would severely restrict carbohydrate consumption. This diet was by no means a cure. It essentially brought children with diabetes to the brink of starvation in order to briefly control the disease. Within this context, the discovery of insulin was a medical miracle. Here you can see two photos of the sixth child ever treated with insulin. The first photo is taken prior to insulin treatment, while she was following the starvation diet, whereas the second photo is 4 months later, after being treated with insulin. You will notice a significant increase in body weight that has occurred. The discovery and production of insulin allows those that cannot normally produce the hormone to control their blood glucose levels. Today, type 1 diabetics use daily insulin injections or an automated insulin pump to maintain glucose levels. The insulin pump can release long and short acting forms of insulin to mimic basal and post-meal insulin levels. Coupling an insulin pump with a blood glucose monitor allows glucose levels to be constantly monitored and the amount of insulin released by the pump to be constantly and dynamically adjusted. If too much insulin is administered, then the life-threatening condition hypoglycemia can occur. Hypoglycemia can also result from missing a meal or unplanned physical activity, where sugar levels are too low to provide for the body's needs. In this condition, an individual's blood glucose level drops below 4 millimole per litre, which can have some significant systemic effects, as shown in this diagram. To treat someone for hypoglycemia, they would be given sugar, provided they are conscious. In the event that they are not conscious, they would be administered either glucagon or glucose intravenously. In terms of new approaches for treating type 1 diabetes, TrialNet in America is testing two recently developed monoclonal antibodies. Currently, they are trialling these drugs in individuals in stage 1 or stage 2 of this condition. This is when autoantibodies are present, but symptoms are not yet obvious. The goal of these studies is to prevent the autoimmune responses that would ultimately lead to the progression to stage 3 or overt diabetes. These trials are ongoing, but in earlier studies with newly diagnosed individuals at stage 3, these drugs were able to improve insulin production and delay insulin loss, which means they were able to preserve the activity of the few remaining beta cells. For those with type 2 diabetes, a change in lifestyle, which includes weight loss, a change in diet, and an increase in exercise, is the best way to reduce blood glucose and lipid levels and to manage their condition. A variety of therapeutics are also available, such as metformin, which increases glucose uptake and decreases hepatic glucose production, GLP-1 analogues, which improve pancreatic islet glucose sensing and improve satiety, sulfonylureas, which increase insulin secretion from pancreatic beta cells, and TZDs, which decrease lipolysis in adipose tissue, increase glucose uptake in muscle, and decrease glucose production in liver. If these drugs are not sufficient to maintain glucose control in type 2 diabetics, then insulin may ultimately be required. So that brings us to the end of this presentation. We have learned about the acute and chronic complications of diabetes and the treatment options available. While the rapid rise in the incidence of diabetes is a major concern, new research and clinical trials provide some hope for the effective treatments in the future. Be sure to go through the activities below and talk with other students on the forums or tutors in the class if you have any concerns or questions. I'll see you next time.